And welcome everyone. It's 7:01, so we'll go ahead and get started. I appreciate all of you for coming on tonight. Looks like we have a good list of people coming on. So I'm Dr. Ken Zweig with Northern Virginia Family Practice. Hopefully we're all in the correct location for this. Tonight is our town hall, and we are excited for tonight to have a recurrence of a town hall that we did about a year ago that unfortunately we did not get to record for some reason. We're not even still sure what that was, but it was so good. I think it is worth repeating. And so we are doing a town hall tonight again on chronic pain. And the reason why we want to do this is something that is really important. It can be something that's devastating to so many people, and it's incredibly common, something that me and all the other physicians in our practice see quite a bit. And chronic pain is something that affects about 20% of the US population. So it's very significant amount. And it's debilitating in over 8% of people in the US. And so that might not sound like a lot, but that's diabetes is, you're talking about 4 or 5%. So this is a really significant condition that is very prevalent and very difficult to treat for a lot of people and can really change lives. So it's something that we would like to treat and would like to figure out how to treat better. We have a lot of treatments. We have a lot of medications that are adequate at treating acute pain, but for chronic pain, we do have treatments, at least on the medication side of things, but they could be better. We don't have great medications and great specific treatments. So really, when it comes to treating chronic pain, as we'll hear, it's really more of an all-encompassing approach where you have to take on multiple aspects to get people feeling better. And so, but it is something that can be treated. And so, and one of the mainstays of therapy is physical therapy. And so that's why we have tonight two outstanding doctors of physical therapy to present to you about chronic pain. And so back by popular demand, we have two doctors of physical therapy from MovementX, the people who bring you age-proof your body. The first you may know is Dr. Fred Gilbert, who presented last time. And Fred is, again, a doctor of physical therapy and specializes in orthopedics. He is also certified as a manual physical therapist, and he received his doctorate from the University of Alabama in Birmingham and a Bachelor of Arts in Biological Sciences at Clemson. And he has a special interest and experience in treating chronic pain. And with him tonight, new to both MovementX and to the town hall, is Dr. Dan Alcorn. Dan got his degree, a doctorate in physical therapy from George Washington University, and he has been working in Northern Virginia for about 12 years actually, before joining MovementX. And Dan is an expert in upper body injuries, which is something that we've been looking forward to because we have so many people with shoulder and elbow injuries. And so Dan specializes in this. And so we're excited for both of you to join us tonight. So I'm going to let them take the ball and run with it and talk about chronic pain. Thank you so much for joining us.
Awesome. Thank you for having us. And hello, I'd be remiss not to say hello to my mother who is on this. So hello, Mom. Dan got a kick out of that. I can't see you, Mom, so don't worry if you're cooking or something. But anyway, hello and hello to everybody. And thanks for having me back. And I'm excited to have Dan. Like you mentioned, I grew up in Alabama. I've been with MovementX for about 4 years. And one of my stories I tell all the time is actually from MVFP in our first age proof class, watching people over 8 weeks go from arguing with me about doing bridges on the floor to doing full unmodified burpees by week 8. For those that may not know burpees, that's chest to ground, kick your feet back, jump up and jump back up. And my favorite too is two sisters that were in their 90s that were the first people down every single time we asked them to do it. So NVFP is a very special place in my heart, and I'm super excited to be back on tonight. And then we also have Dr. Dan.
Thank you so much. Thank you, Dr. Zweig, for the introduction. My mother is not on the call. If things go off the rail, I'll be giving the signal to my 5-year-old daughter, and she will make an entrance to save me from myself. But yeah, I would like to echo Fred's sentiments, just of gratitude for this opportunity. I've had the opportunity to work with a number of the clinicians from NVFP during my career, and just outstanding clinicians. And I think this is just the tip of the iceberg, having a community outreach event like this. And I can't thank you guys enough for this opportunity and just for promoting this to the community. So looking forward to talking all things chronic pain.
Great, and thank you. And we feel the same about you guys. We really enjoy having you part of the team and sending our patients to you. I think you do a fantastic job, and everybody is always pleased.
I love it. Yeah. And just a brief overview for those that may not be familiar with us. So we're with a company called MovementX. So we're a mobile and digital physical therapy company. And we serve a lot of the DMV, but we're also in states across the country. And so afterwards, if you have any questions about that, we can tell you more about our mission to create a world that's healed by movement. So we're excited. A part of that is certainly helping individuals navigate persistent pain or chronic pains. We're excited to give that brief piece today, and then can be of service, hopefully, to people both in our area and across the country as well. So super excited. So tonight's topic is chronic and persistent pain, which is a pretty broad spectrum, right? You go and define chronic pain, and it's basically anything that lasts more than 3 months, which is pretty broad because if you've ever known anyone that identifies as having chronic pain, it could be anything from, oh, my back bothers me, every day, but it's pretty low level, but that would be chronic, to I cannot leave my house because the pain is so bad. And so the broad spectrum and also oftentimes mixed presentations of symptoms can make it pretty difficult. And so what we want to do tonight is try and break down some of those barriers to demystify chronic pain. And particularly, we want to bring a point of view that takes the locus of control or where you feel like the control exists from the medical world, which is I need someone to heal me, to these are some steps that I can take to start to work on that process myself. And so we want to present some high-level options and try and simplify it. Dan's got a really nifty acronym for you all. I'm building it up, Dan. Just be ready for that. I'm just building it up. And so we're excited about it, but I do want to set a little bit of context. So tonight, a couple of things that we're going to do are talk about things that you can do yourself, right? So we'll talk about strategies that you can own. What I don't want you to hear in that is that we're blaming you for not having tried these before, right? Because a lot of them are relatively simple sounding and harder to perform. So all we want to do is come across as, hey, these are possibilities. And then your team at NVFP or your team at MovementX or your local team, whoever your health team is, can help you guide to those things, your community, your friends, your family, et cetera. We're also going to talk about some of the myths surrounding chronic pain, particularly in the imaging space, like MRIs, X-rays, et cetera, surgeries, as well as medications. And what we don't want you to hear is that we're blaming medical practitioners. So we don't know the context by which you've been prescribed things. We don't know the context by which surgeries were chosen or activities were chosen. We want to give you information for you to then go and look at your care more holistically. So when we talk about a surgery, or if we talk about a pill or an image, we don't want you to feel like we're blaming or saying that somebody gave you bad care. It's just, these are the standards, and then we can help you navigate to care that you can do for yourself. And the final one, and probably the most important, is I will go ahead and let you know that you will think to yourself at multiple points, yes, but in this presentation. So you may say to yourself, yes, but it's different for me, or yes, but that wouldn't work for me, or yes, but that would be too hard for me. And what I want you to do, or encourage you to do, is every time you think that, I want you to just jot down the topic that we were talking about and come back to that after the presentation, because oftentimes that's where the healing comes, is when we believe something differently. So when Dan talks about exercise, and you might say, yes, but I can't do that. That would be too hard. Well, let's find some time to explore that down the road, because that's likely where the biggest growth for you is going to happen. So as you start to feel yourself disagreeing or arguing, certainly we'll put it in the Q&A and put it in the chat, but write it down, because that's likely a space that you can reflect later and grow on why that feels like a sticking point for you in your journey with chronic pain. So with some context set, also just know if I look up, I've got all my notes up here, so I'm just looking at those, and I don't know where Dan's are, so he may be looking all around. His are below, where his daughter is, to bail him out if he needs it. So when we look at the world of chronic pain, like I mentioned, it's anything from 3 months and beyond. And when you look at the typical standards of care, a lot of times what happens in the medical system is individuals have pain for a long amount of time and they immediately enter into a cycle of imaging, right? Something hurts, let's get a picture of it. Dan will talk in a little bit about the misconceptions around imaging and what it actually tells you. But what will often happen is we'll get an image, we'll see a thing, and we'll try and fix that thing. There was a study done that looked at a lumbar fusion, which is a really, really common solution or an attempted solution for low back pain, and low back pain being one of the more debilitating forms of chronic pain. And what they found was this lumbar fusion, which is a pretty big deal, right? You get this cage put into your back and it really limits your motion. It also comes with some pretty hefty rehab and changes in lifestyle behaviors. What they found was the number one reason that people chose that surgery was not symptoms, it was not history, it was not presentation of pain. It was simply the zip code that somebody lived in and whether or not the doctor would prescribe it or the surgeon would prescribe it or not. And you can look at the same that same pattern happening amongst other procedures. And so what we found is the systems with which we diagnose pain are pretty unreliable for the layers that come with chronic and persistent pain. So it's oftentimes not the structure, it's oftentimes how we're moving around the structure, how we're behaving in other parts of life, and also how we think about that structure and pain. You see the same thing with the opioid crisis that's developed. We've tried to overprescribe a medicine to dull the pain. The irony behind the opioid prescription, in addition to the addictive qualities, is opioids actually increase pain. They actually, over a long period of time, make pain worse. They don't make pain better. And so that's one of those typical trajectories is let's get an image, let's have a surgery, or let's take a pill in order to alleviate those. And as we've seen, 8 out of 100 people, as Dr. Z mentioned earlier, have chronic pain. It's not dealing with the issues that we have. And so what we end up hearing, at least by the time they make it to us, is, well, you just have to live with it, right? This is just a thing that you need to live with and you need to deal with. And as somebody who, I'm sure many of you on this webinar have had chronic pain or currently exist with chronic pain, that's a pretty deflating thing to hear. And so what we want to do throughout is Dan's going to break down a couple of myths for you, and then we're going to go into some solutions that you can take that control back to say, well, yeah, this might be something I have to live with, but there's also a lot of things that we can do to try and manage this persistent pain. So Dan will go through a couple of the myths right now.
I just had my first yes, but moments when I realized I had to follow that up. That was beautifully poignant. So here I go. Yeah, I'm going to start with busting some myths, and please just remember I am but a middleman, so don't take it out on me. I'm just presenting, and do with it what you will. I also want to start with a bit of context before I get into these myths. And I think something that's really important to note is that a lot of our patients that present with chronic or persistent pain are also presenting with depression, high level of fear avoidance behaviors, and catastrophization. And I think it's really, really important to keep these comorbidities and these yellow flags in mind, because they have a huge impact on the course of care and also the outcomes with these patients. And we need to be very holistic in our approach because these are oftentimes present. And I would like to give a shout out to Jessica Ware. I've had the pleasure of shadowing her twice in clinic, and I've seen her firsthand take a very proactive and direct approach with depression screening and talking to her patients about depression and anxiety and making sure that that is addressed as a component of their care. Because if it is not, we're not doing everything that we can for these patients. So I wanted to start with that, and now to get into the myths. So the two myths that I want to discuss, the first one is the medical community, and we tend to have an over-reliance on biomedical education. And I want to say outright, I get it. I completely understand. One of the top things that a patient wants to know when they seek out care is, what is wrong with me? And we as clinicians got into this business to help patients. And so when a patient wants to know what's wrong with them, we want to give them an answer. And the biomedical answer is very direct, it's concrete, and oftentimes it's actionable. And so it makes sense that we want to rely on that. The problem is that many of these patients have had pain for years, if not decades. And once you've had pain for years and decades, it gets really hard to place the focus on one specific tissue or one specific diagnosis. In addition to this, a lot of these patients, if they've had pain for years, if not decades, they've seen many healthcare practitioners. And the likelihood is they've been given as many medical diagnoses as they've seen healthcare practitioners. And that's not to say that all these healthcare practitioners are wrong, but a lot of these different diagnoses, especially when we're talking about the lumbar spine, they have very similar presentations. And so we could all be giving you different diagnoses, and in the end, our treatments are going to be very similar. But if I'm a patient that's receiving all these different diagnoses, that can be a little disheartening. And in addition to that, it can erode some of their confidence in us and practitioners and in their ability to get better, because they leave with 5 different diagnoses and they don't really have a sense of what's wrong with them. And what the research is actually showing us is that in this population, this chronic pain population, the use of biomedical terms, especially degenerative terms, are associated with a poorer prognosis. So these are things like wear and tear, deterioration, disc space loss, crumbling, collapsing, things like that. What we can do instead, we want to educate them about their pain, and this needs to be contextually appropriate. And we need to educate them that this is oftentimes, especially in their case, multifactorial reason that they have pain. And this can be really tricky in a short patient setting. We don't have so much time to work with these patients. And so it's hard to get into these really just, dense, just nebulous topics. And so the big thing is identifying with your patients what are the stressors in their lives and helping to educate them on how these stressors play a role in their experience of pain, and explain to them in some way that pain is an output. It comes from our nervous system, which is our body's alarm system. And its job is to respond to stressors. And when these patients have chronic pain, oftentimes the alarm system gets revved really, really high. It's extra sensitive, and it's responding to things much more sharply, much more acutely than somebody whose alarm system is just kind of humming under the surface. And this, tying that to the specific stressors in their lives, can hopefully help them connect the dots of how their pain isn't necessarily related at all times to specific tissues, but related to the circumstances in their lives.
Yeah, and there was an interesting study, and I apologize, I can't quote the author of it right now, but Dan, you might know. There's an interesting study published several years ago that looked at MRI findings. So very, very common for diagnosis of musculoskeletal injury. So any pain that you might associate with a joint or a certain movement, right? Low back, shoulder, ankle, etc. And so this study looked at low back pain, which is very, very, very prevalent in the population. And what they did was they took participants with no symptoms, right? So that's a really important piece to this study. They had no symptoms, so no pain, no nerve issues. They didn't report any dysfunction with their back. And what they did was they took MRIs and they looked to see just what they could see, right? What do we see on the MRI? So, and I think the youngest age was in their 30s and oldest was in their 90s. And what they found was there was no correlation between dysfunction and imaging. So there were degenerative discs, there were loss of disc height, there were bone spurs, there were disc herniations, there were, bulging discs everywhere you can think of. And the only correlation came between the age of the individual. So as you got older, the more those findings showed up. But remember, none of them had symptoms, right? None of them had symptoms. And so my favorite thing that came out of that study was a phrase: if you walk down the street and you see somebody with wrinkles on their face, you would probably think either they've been in the sun too much, which is never my problem, or they have aged, right? We see wrinkles on the outside and we think they're just getting older. Same thing with MRI findings. The wrinkles on the inside are as normal as wrinkles on the outside. And so one of the dangers we run into, as Dan was alluding to, with chronic pain is if you try to look at a structure to make a diagnosis with something that is so multifactorial, it's like you're watching just one frame of a movie instead of the entire thing passing by you. And so it makes it really, really tough to accurately not only diagnose, but accurately treat that and work with that individual to go back to healing.
Yeah, and to build on that is myth number 2, and that's the early reliance on imaging. And again, I get it. The desire to provide a concrete diagnosis and to provide direct and actionable help. But as Fred alluded to, we know through the research that it's images. And I see, the literature, especially for shoulder patients, as Dr. Zweig mentioned, I see a lot of shoulder patients, but the same is true for the lumbar spine. And with these patients that have chronic pain, they have pain. And that these patients have had pain for, like we said, years, maybe decades. They're probably going to have positive. What we talked about, myth number 1 is that biomedical education often does not go well with this population. MRI in front of these patients, we're feeding into that. And so what my takeaway is, if you're going to get imaging, what do you plan to do with the information from the imaging? So we know that from a patient education standpoint, it's not really going to be a huge value add. So if you're going to get imaging, my thought is, okay, we're going to use that for directing injections when we're talking about the lumbar spine. We're going to use that for deciding on surgical options. And those are important, but why not try PT first? And our goal in PT with these patients is not that we're trying to reverse tissue damage. We're trying to build confidence through movement. And we're trying to improve ownership of their pain experience and give them back control over having a positive impact on this experience. And we're trying to give them self-efficacy, that they can engage in an actionable process to tackle pain. And I don't want to fight an uphill battle against all of this biomedical information until I want to refer to, an interventional physician for injections or for a surgeon for that surgical consult, because I'm going to treat with this approach that we're going to get into, really regardless of what the image findings show me. So that's kind of our plug for, imaging is important, but it might not be the best first option for these patients. And I will kick it back to you.
Kick it. Also, one of my coworkers gave me a new mic setup. So if I look like I'm intentional, my mom can attest, I always ham things up, but if I'm doubly hammy, it's because I have this new microphone set up. So it's kind of working through a transition into some of the more actionable stuff. One of the most interesting findings to me is if you look at, and I treat a lot of spinal conditions, right? So spine is where I spend a lot of time, much like Dan spends a lot of time with shoulders. The number one indicator of whether or not you'll actually recover from low back pain is not whether you do a certain intervention or whether you see, interventions being surgeries, pills, PT. It's whether or not you believe that you can get better. And so one of the things that honestly that we hope comes out of this is that you can start to believe that you can actually get better from the condition that you have. And there's a lot of evidence starting to emerge around the belief systems and how those directly impact it. And one of the most important things, and honestly one of the harder things to oftentimes for individuals to name or to identify, is this concept of our inner voice, right? So I guess my body really wanted me to be very in the moment for this presentation, because I've had chronic back pain since I was, 20. I think my first episode was at Clemson. I slipped on some like mulch and had a really bad back flare up and came home, got a massage, tried to figure it out. I'd never been to PT before I became a PT, and it's plagued me ever since, right? And fortunately, where I used to have 6 incidents a year where my back would seize up, now I have one every 4 years. And so I happened to have one right before we had this talk. And I have this inner voice, and I've decided to name him Jerry. That's what I'm going to call him. And I say that half jokingly, but one of the toughest things for us to come around to in chronic pain is knowing when we're listening to actual relevant symptoms. So whether or not there's an actual emergency symptom, or if it's Jerry telling us that we should overreact to something. And when I think about that, I think about two examples. One, if you've ever watched a kid fall down, right? Kid falls down, scrapes their leg. They look around to see how they should respond, right? If no one reacts to them, the kids oftentimes just get up, walk away, say it didn't feel good, and they go on. If everyone starts coming over and trying to say, oh, are you okay? How are you doing? They start to sob. And we do that as adults, right? Jerry wants to come up and say, oh, how are you doing? That's really scary. That really hurts. You're probably hurt. You should take it easy, or maybe you should start to freak out a little bit. And so Jerry, for me, is when my back starts to grab, everything wants to start panicking. It starts to seize. I start to feel symptoms into my hip. And if I sit there, and now I've done the work to be able to say, hey, Jerry, I actually said this out loud in my kitchen yesterday. I said, hey, Jerry, it's okay. Like it's fine. My back's okay. And so one of the tougher things is going to be, and this leads us into some of the solutions we're going to offer, is learning how to pay attention to what's an alarm bell and what's actually just a normal symptom that you would have, whether or not you had slipped and fallen, or whether or not you had, mine was doing burpees or devil presses the other day, Dan, that was what got it. But so listening to that inner voice. And one of my favorite stories is, and this will lead a little bit into what we do, is I had a patient one time, she was a younger woman, and she came to me with both arms tingling, right? So forearms and hands tingling. And I treated her inside of her place of work. She was a fitness instructor in DC, and I would go in and she'd be like, yeah, I think I've got carpal tunnel, which is a very common thing to hear, right? We've all likely been, known someone or had a diagnosis of carpal tunnel. And so when I started digging into it, I was like, man, like nothing really seems off. Like her motion was good, her strength was good. I knew she was really active, and we got to talking more. And it turns out that her symptoms only existed. She really hated what she was in of city to quit her job, but I was like, maybe we should look around. And she actually put in her notice that next week and her symptoms totally resolved. And so for her, her big scary voice was, as soon as she walked down the stairs to work, her symptoms came on and her pain returned. As soon as she left, the symptoms went on, rather than run away from it, trying to look at what it's trying to say. And so that's where I say, take notice of when you start to think that doesn't sound like me, or yes, but take note of it. And then these solutions are ones that we hope can be your way to start to mitigate that big and scary. It's, hey, this is bothering me, but I'm doing all of these things and I know it will get better. And so that leads us into Dan's very snappy, like that, Dan, acronym of SNAP, and he'll go through that and then start on two of the components of it.
My name is Dan, and I too have low back pain. And I have not yet named my low back pain alter ego, but I am open to suggestions from the audience and from Fred, because Jerry is a pretty sweet name. So yeah, so we spent the first portion of this topic, diving into all the things that we've done wrong. And I think it's important to really to apologize to our patients that it's gone so poorly up to this point. And we're getting into healthcare because we want to help people and we're doing our best, but we want to do better, and so that's why we're here tonight. And so again, what we want to try to do is give patients control back, and the way to think about it is just control what you can control. And so, as Fred alluded to, we have come up with the catchy acronym of SNAP. And the letters involved in that acronym are sleep, nutrition, activity, and psychological wellness. And so we want to dive into those a little bit deeper with you guys and talk about how we can incorporate that into our treatment, and also how patients can incorporate that into their daily lives. And so I'm going to start with sleep. And I'd be remiss if I didn't start with sleep, one, because it's the first letter in the acronym, but more importantly, it really is the foundation of health. If we don't sleep, can we truly be well? The answer is no. If we don't sleep, we will die. A fun fact, not so fun fact, that I learned recently is that the Guinness Book of Records has officially stricken from their record book the longest lasting person without sleep, because it is so harmful to our health and wellness that they don't want people testing the waters with sleep deprivation. And the Guinness Book of Records allows some crazy stuff. So if they are not going to permit people to go through sleep deprivation, then you know that this has to be just horribly, horribly bad for the body. So always, always, always talk to your patients about sleep. And it's a really challenging conversation to have, because a lot of our patients are hard chargers, and sleep is the one thing that tends to get kind of swept under the rug. It's the whole mantra of, I'll sleep when I die type of deal. I've got too much to do. I've got too much to focus on. And, that, I think that's going to require a paradigm shift, and it's going to require us addressing it head on with multiple conversations and trying to tackle it in multiple different ways until you find something that resonates with that person. And one little factoid that I wanted to bring in is again, because I see a lot of people with shoulder pain, there was a demographic study that was done at the University of Texas Southwestern over the course of multiple years. And they basically just took note of every single patient that came in with shoulder pain. And on their intake forms, they're asking all these questions. And then one of the questions that they asked was, do you have nocturnal pain? And do you have disrupted sleep? And of over 1,000 patients at the time that I looked this up, that were asked this question, 98% of them said, yes, I have nocturnal pain, and 91% of them had disrupted sleep. So again, I'm going to extrapolate that to chronic pain, but my guess is that the vast majority, if not all, of your patients have sleep disturbances, and that is a huge problem. And so what can we do about it? We really want to try to make this as simple as possible. And I recognize this, I'm saying that it's simple, but it's definitely not easy, because we're trying to change ingrained behaviors and we're trying to undo things that have kind of been set in stone. They're oftentimes baked in. So it's going to require a lot of nudging, a lot of practice, and a lot of collaboration with your patients, and a lot of compromise. The first thing that I would say is you want to talk to your patients about having a consistent sleep window and allowing for sleep opportunity. And so what I mean by that is having a consistent bedtime and a consistent waking time, whether it's a Monday or a Saturday, a vacation day or work day. And we're trying to give the body that consistency that it craves. And we don't want to keep throwing things at it from left field, especially when people with chronic pain don't handle stress as well. Their stress resilience has been diminished by years and years of pain. So consistency of a sleep window is hugely important. And I think a lot of us are aware of, oh yeah, the average adult needs 8 hours of sleep, but that doesn't mean going to bed at 10 and getting up at 6, because what we talked about already is that 90% of people with shoulder pain have sleep disturbances. So if I'm only giving myself 8 hours of potential sleep, the likelihood of me getting that sleep it's not going to happen. So we need to talk to our patients about carving out time to allow for these sleep disturbances and understand that those things are going to happen. And we want to set them up for the sleep opportunity to get as close to 8 hours as possible, knowing there's going to be sleep disturbances. And then the next point that we wanted to dive into is really when somebody has pain, the simple way to think about it is the alarm system is revved up. The body is in a state of fight or flight, and that is not conducive to rest and relax and getting a good night's sleep. So we want to be very purposeful and direct with trying to set that person up for success and rest and relax at the end of the day. And so a good way to look at this is after dinner, that time between dinner and bed, you're trying to set yourself up for a good night's sleep. And this can be really anything that the patient agrees with. And some of these things that come to mind for me are gentle movement, especially given that we work for MovementX and it is in our name. So if we can find ways for them to move, especially ways that help them relax, all the better. A breathing pattern, being purposeful with your breathing can be really helpful to promote a state of relaxation. Again, the tendency is that when we're in pain or when we're in a state of stress and alarm is we hold our breath. And so if we can take the other side of that and be purposeful with our breathing, we can hopefully have a positive impact on relaxation. Other things that also fall into this similar category would be things like meditation, reading, taking a hot shower, and journaling. And again, I don't want to tell people what to journal about, but if we're talking about how to have a positive impact on the pain experience, I think it can be beneficial to reflect on the day and how their body responded to the stresses that they were exposed to, and looking at one or two positives of how they handled those stressors. And one, it helps to kind of reframe those pain-provoking experiences. And then two, it kind of allows them to reflect and build off of the things that they found successful. And if they're able to identify that, all the more powerful, because that gives them ammo to work towards something directly the very next day.
Yeah, and the only additional piece I'd add to that with sleep is one of the and I'm trying to remember where the study was, but I looked up the basic tenet of it. One of the biggest indicators of pain level, right? So how intensely pain will present is number of hours slept, right? And so one of the takeaways from this is yes, prioritizing sleep. And we actually have a handout of like 10 sleep tips that I can send that I roughly created in our graphic design software one day. So don't judge the design so much as the content. So there's kind of two opportunities, right? There's, hey, let's look at some opportunities, consistent sleep and wake time, consistent bedtime routine. My bedtime routine is the same. I brush my teeth, I come in, I lay down, I read my book for sometimes 5 minutes, sometimes an hour. And it totally depends on my wind down time. But every time that I continue my routine, I fall immediately asleep and I sleep my 8 hours. As soon as I break that with something like a phone or an iPad or even just a change in behavior, my sleep quality goes down. And so there are opportunities for sleep habits. And if you're experiencing chronic pain, or if somebody is experiencing chronic pain in your world, if nobody's talking to them about their sleep, that should be one of the #1 priorities for how they pursue medical care. And so if the first thing that someone, medical practitioner says is, hey, let's talk about this pill or the surgery, the deviation in the conversation needs to be, let's talk about my sleep first. I'm not sleeping well. How do I manage that? And that's one of those really powerful changes. And it's also a way to know whether your practitioner is really going to be able to help you. If they're not talking about sleep, nutrition, activity, or psychological wellness, they're probably not a space of healing. And so that is one of the major takeaways with the sleep portion is the more that you sleep, the more that pain goes down. And that's a natural regulator that our body has. And so prioritizing that as part of a healthy part of healing is #1 priority. If you take nothing else away from this presentation, prioritizing quality sleep is the most important thing that you can do. And that's coming from a movement company. We love movement. It's the next one he's talking about. But if I got 1 quarter to play in a slot machine, I'm putting it into the sleep. That's what I'm doing. Dan, I think, would agree.
Absolutely. And I will let you go next since you are the end.
I am the end. Nutrition is a super quick one. As a note, I'm not a dietitian. I am a physical therapist who is made a study of chronic pain. And so two really quick. One is actually a build on sleep. So one of the things we talk a lot about in pain science is both the beliefs we have around it. What do we associate, right? For me, when I walked into a certain room at a certain job that I have, I became short of breath, right? My patient that had the tingly fingers, every time I stepped down off of a curb, right? So there's those pieces. But there's also pieces to it that are kind of that I word that we all know to fear a little bit, which is inflammation, right? And so a couple of interesting factoids when you look at inflammation related to pain is they've done studies looking at added sugars, and added sugars were 49% or related to a 49% increase in the odds that you're going to experience some type of chronic spinal pain. So just simply having added sugars in the diet can result in higher inflammation chronically or globally throughout the body, which makes tissues more sensitive to both stretch and compression, and also just more likely to experience those sensitized pain structures. And so when we talk about nutrition, there's a whole bevy of it, right? What you eat is how you feel, and gut health is incredibly important. But a lot of the first mainstays when I talk to patients about their chronic pain is, let's look at how we can modify added sugar intake, right? So added sugar meaning obviously granulated sugar, but also, the cakes, the bagels, the simple sugars. And that's not a vote for don't eat. It's a vote for pay attention to what it does to your body. There was an interesting study. A lot of times when I work with people with persistent pain, they talk a lot about nerve symptoms, right? So that symptom down the leg or the shooting pain symptom. And we always associate that with, oh, the nerve's getting stretched or the nerve's getting pinched, or that's my sciatic nerve getting pinched again, right? So this was an interesting study where they actually attached rubber bands to nerves. And without any type of irritant, so in this case, we'll call irritant inflammation, without any type of irritant, the nerves actually don't care. They can be stretched, they can be compressed, the rubber band can be tightened, and no symptoms occur in the patients they were doing this with. As soon as they irritated those structures, so they added inflammation, again, sugar equals inflammation, the structures became sensitive. So they experienced sciatica, they experienced those down the leg or down the arm symptoms. And so if you're somebody who experiences that radiating, that spreading pain, pay attention to what our sugar intake looks like, because it's likely that could be making everything slightly more sensitive, again, through that inflammation pathway. The other vote for the nutrition side of stuff is make sure that you're fueling the body enough. One of the things that we see, particularly with older adults, is our food intake goes way down. And so for various reasons, right? We're not as hungry, we are not as active, so we're not as hungry, or we're trying to watch our weight, right? Like everybody has that mentality. And what can often happen is if we're under eating or under fueling, our body can't replace what was there. So I had a mentor who had a patient in North Alabama who came in with persistent hip pain, and it had been going on and on and on, and nobody could figure it out. And so my old mentor took a look, did the eval, couldn't find anything wrong with the muscles, the joints, the ligaments. And he started asking about his diet. And the guy said, yeah, well, I switched to a vegan diet recently. I said, well, how are you getting your protein intake? And he was like, well, I eat an 8-ounce thing of hummus, which for those involved, 8-ounce thing of hummus is not a lot of protein in a day. And so my mentor said, well, go home eat some more protein, don't care how you get it, triple down on the hummus. And so he comes back and his pain is gone. And my mentor says, what happened? And he goes, well, I went home and ate a steak. And so the steak didn't heal it. The increased protein intake healed it, but it was an under eating and under nutrition, and the body never got a chance to rebuild and refuel. So a couple of questions that I would always have for my individuals with chronic pain is A, let's look at the sugars. Let's pay attention to where those are coming from and how they might affect your pain. And B, and honestly, probably more relevantly in most, are you eating enough food? Because oftentimes individuals with chronic pain will drop that food intake and they never get a chance for their body to heal or to build back stronger, no matter what interventions they're trying. And then Dan, you got activity, SNAP.
All right, moving right along to A. So activity. Again, we are a movement-based organization. And so this is right at the heart of what we love doing most. And our bodies are meant to move. And the way that I look at this, again, I have a 5-year-old daughter. How am I doing? Do I need to call her in or staying on the rails? Okay. So I tend to look at really everything through the lens of my 5-year-old daughter, but especially when it comes to movement. And I think the more we can channel our inner childs, I think the better off we're going to be. And if you ever watch a 5-year-old or any young child, they just never sit still. They're just constantly bouncing all over the place. The frequency and the variety of their movements is just, it's astounding. It's truly mind-boggling. And I don't pretend to think that we're all going to move with that same vigor. It'd be awesome if we did, but working towards that end of the spectrum, I think is of huge value, especially with people with persistent pain. A lot of the chief complaints for people that we work with persistent pain is prolonged something. So I have difficulty, I have pain with prolonged sitting, with prolonged standing, with prolonged walking, with trying to concentrate in meetings, with whatever usually the longer the duration of the activity, the more challenging it is for this person. And so if we're being very purposeful with taking little movement breaks, then we can stay ahead of that stress building up associated with inactivity. And so again, trying to convey things that are easy to remember and implement, think about the 20-20 principle. And so every 20 minutes, taking a 20-second break to get up and move. Step away from your workstation, step away from whatever your activity is and move. And I don't get too dogmatic about the specifics of that movement. I just want them to move gently. I don't want them to shock the body. I don't want them to overwhelm the body, but I want it to be specific. I want it to be targeted. And again, the more variety, the better, channeling your inner child. Also, and this is a conversation that is definitely worth having with your patient, is what movements are important to them to reclaim. And so if there's a movement, I'm again, in the child mindset, you have a grandchild and getting down to the floor to interact with your grandchild is important to you, but having a fear of getting down there, being able to stay down there, being able to interact and being able to get up. Well, what if we just break that down to 20 seconds? And in whatever way you can, trying to lower yourself down to the floor and then get back up. Again, making sure that you're safe, but attaching meaning and value and not just giving them some arbitrary movements becomes much more powerful in the person's willingness and desire to be consistent, because it is a lot to ask for somebody that's in pain to move with frequency like this. And again, 20 for 20 is it's meant to be catchy, but some people have trouble sitting for 15 minutes. So if they have trouble sitting for 15 minutes, then having them move every 20 is, we're not doing enough. So we have to be very specific with the patient's needs and telling them, stay ahead of that stress buildup. And if you know that sitting for 15 minutes is going to set you off, then get up every 10. And again, we're just trying to be purposeful and be specific for the person that is in front of us. And so channeling your child's 20 for 20. All right. And then the second thing that we want to talk about with regards to activity is we want to be purposeful in building up these patients' tolerance to stress. So anytime you've been in pain for, again, years, if not decades, your body's tolerance to stress is going to be negatively impacted. And the way that we think about stress tolerance from an activity and a movement standpoint is another acronym for you. This one is SPAMS. SPAMS, yes. I would not put that in the superfood category on Fred's nutrition side of things, but it's good as an acronym for activity. And so when I'm talking about SPAM, I'm thinking strength, power, aerobic endurance, mobility, and stability. And I look at this as a comprehensive way of approaching movement and activity and building stress tolerance. And I'm going to commit the cardinal sin of going out of order. And I'm not going to go through SPAMs just because I tried to make it something that you could remember. But I want to go through the priorities of how I'm going to address this with my patients. So the first thing that I want to talk about is the M portion of SPAMs, and that's mobility. And this is the first step. This is the foundation. We talked about sleep being the foundation. I think mobility is the foundation for movement. And when I'm talking about mobility, I'm defining that as improving your ability to move your body through large ranges of motion. And mobility is a prerequisite to all of the other pillars of movement, because you can't perform well in a position or in a movement that you can't physically get into. So the first step is to achieve success in getting into these positions and improving these motions. And then once you've achieved that mobility, you then want to layer stability on top of that. So stability either being the first S or the last S, depending on how you look at it in SPAMs. But stability, what I talk about that is your ability to demonstrate active control of the full range of motion or of the full activity that you're trying to achieve. And a lot of times when you're in pain and you're not able to get into these positions repeatedly, you lose the active control to be safe and stable in these positions. So once you work on possessing the motion, you then want to demonstrate active control in these motions. And again, all of these pillars, we're kind of talking big picture, but these are things that physical therapists work with day in and day out. And so these are things that they can definitely help your patients, regardless of what their tissue specific sensitivities are. They can help them with these pillars. And then the next S, so the first or the second, is strength. And so I think this one is easier for us to wrap our heads around. It's a lot of your traditional fitness programs. And we're trying to build the capacity to generate force through these ranges of motion that we discussed in the mobility section. And strength can be many things to many people, but really with the person in front of you, can you help them get down to the ground? So if they want to interact with their grandchild, can you help them build the capacity to get down to the ground? They've been practicing it through their 20 for 20 approach. Now we want to train them with these types of activities so that they have the capacity to do it over and over again, or to do it while holding their 30-pound grandchild, or to do it while trying to get the Peppa Pig doll out from under the couch. You know, whatever the case may be, we want to build their confidence and their capacity. And then moving right along, we have power, which is the P in SPAMs. And defining power, I'm saying the rate at which work is done. And basically from a actionable approach is, can we maximize speed with our force production? And I think that this is something that it's something that I've come around to more recently with people with pain, because with this population, when you have pain and when you have guarding, the tendency is that you slow things down and you're much more guarded, so you're less likely to move with speed and with force. And so the way that I think of this is, especially when it relates to falls. And so if you trip, your ability to catch yourself quickly and respond to that trip can be the difference between a fall and a near miss. And this is, I think, important with all patient populations, but especially with our older patients with chronic pain. And so being very purposeful with training with speed as the stimulus. And with this, we want to make sure that we're doing something that they feel safe performing, because if they don't feel safe, then their willingness to act with speed is going to be diminished. So finding things that they feel safe performing in doing them with the intention of being fast and powerful. And then the last item in SPAMS is aerobic or endurance. And this is really just your ability to sustain your activity. And again, attaching that to things that are meaningful to them. But walking, you know, bang for your buck, it's one of the best things that you can do for all around wellness. And so finding ways to build some sort of aerobic endurance, but you know, ideally if they can, and we'll talk a little bit more specifics on how to troubleshoot this, but building a walking program into your patient's daily program. And then I will kick it off to the next portion of our next acronym.
Yeah, and we'll go through the psychological, and then Dan will also keep a little time for Q&A, and I'll wrap it all in together, the last few portions of it, just keeping an eye on time. So the final piece of the SNAP, right? And again, if you walk away, sleep, and then there are some others that we can help you remember. The last portion of it is psychological wellness, and as you may have noticed, I like to teach through stories. So I had this patient when I was in Huntsville, and she'd been to about 5 different doctors for low back pain. And she walked in and she said, everybody's recommending a fusion. She's like, no one knows what's going on. I've had this pain forever. You know, I used to go fishing, and I used to go, you know, I'd go on my boat every single day because, you know, in Huntsville, we have lakes nearby. And I had this big trip planned, and I canceled it. I've been planning this trip for 10 years with my husband for our anniversary, and I canceled it because I have such bad pain. And I remember I got to the end of the evaluation, and I said to her, I was like, you know, I don't really know what's going on. Like, I don't know what's generating your pain, but I do know that there's no big and scaries, right? There's nothing that suggests you need surgery. There's nothing that suggests you need to go and get any type of imaging. It just seems like it's a pretty complex thing that's built up for you. And so I said to her, I said, I think you just need to go try something. Like, I think if you go fishing tonight, you may wake up tomorrow with pain, but you also went fishing and you had the same pain that you would have had if you hadn't have fished. And so we did a little bit of treatment. I think I threw some tape on her back. And I said, just go home and try fishing. So she came back the next week and she said, Fred, I'm 80% better. And that 80% did not last, right? You know, we fluctuated back and forth, but in that moment, she was 80% better. And all that was she just got back to trying things that she loved doing. Because at the end of the day, particularly with chronic pain, you can either experience the pain, or you can experience the pain, but do some things that you love. And oftentimes, because pain's multifactorial, right? I mean, it's all chemicals flowing through the brain. If you go do something that you love, that experience is going to help lessen the pain. And you're going to be people that you care about. You're going to be in environments that you care about, and you're going to be taking advantage of those activities. You know, I didn't say it to her, but fishing is a great balance exercise. She's having to get up and out of a boat. She's having to, you know, cast and be unstable. And so finding things that you love to do, and particularly putting yourself back in environments. And if there's anyone, I see a few names that I recognize from the at least early days of Age Proof. Maybe more people are from Age Proof than I recognize now. But a lot of the beauty of Age Proof was people getting together under the same roof, doing the same uncomfortable things, and just trying to learn and be better together. And it was a really lovely growth opportunity for all of us. And so as we wrap through and open the space a little bit for questions, there's a couple of big takeaways, obviously the SNAP, but one that I think resonates with Dan and I most, it's just try stuff. You know, don't pay as much attention to the pain as so much as progress. If you can go for a 10-minute walk today and a 12-minute walk tomorrow, even if the pain's the same, that's progress. And so finding medical practitioners that can help guide you through that process is important. And also there's a lot of stuff that can be done daily, improving your sleep, finding ways to eat more nutritiously, finding ways to be more active, and finding ways to go be near people to help regulate your mental health. Or, you know, in my case, finding a mental health practitioner that's been quite helpful, and looking for opportunities to weave that into your daily life. And as you or friends or family experience that, you know, feel free to connect them to NVFP. Dr. Z is a really lovely chronic pain practitioner, as well as Dan and I, and Emily Harmon, who's another one with us here in Northern Virginia, and Dr. Z's neighbor. So, you know, he can really get in touch with her if you need to. It's really lovely to talk to people who listen first and then prescribe, which is, I think, a rarity in medicine these days. So leaving a little bit of time, I know we only have 5 minutes, but any questions, comments, takeaways? My email can be available after. That's totally fine to share, as well as my number as well, Dr. Z. That can all go out to people that want to follow up or ask any questions.
That was great. I really appreciate it. This is another terrific talk, and we certainly 8 o'clock is not a hard and fast rule. If people want to stay on, they can. If they want to log off, they can. But if you guys are okay, we can talk a little longer. But I love this. I mean, it was great for most of you out there. What you realize here is, I think a lot of people think when they talk about physical therapy, they think, okay, I'm going to go to a gym, I'm going to lift a few weights and maybe get on a bike, and that's going to be it. And then I'm going to go home. And I don't think people really think about the concept of, a physical therapist taking on a holistic approach, but it's fantastic. And it's the way it should be. And the SNAP acronym is fantastic, not just for chronic pain, but for almost anything in medicine. I mean, that's really all there is to it. And the SN and the A lead to the P. So the better you do with your sleep, your nutrition, your activity, the better your psychological state will be. And so they're all tied together, and they're all equally important. Well, maybe not equally important, all very important.
I mean, they're probably all equally important.
My patients out there, as you guys alluded to, and Dan, you're near and dear to my heart, because the way you talked about sleep, everybody who's seen me knows that sleep is numero uno for me, very, very much right at the top for virtually every medical condition you can have. And as you said, it all starts with sleep. The only two things more important are air and water. After that, sleep is the third most important thing. You can live longer without food, you can live longer without everything else, but sleep is just absolutely critical for everything that you do and for just normal living. So thank you for mentioning that. And I think, Fred, you alluded to this, is that there is a one-to-one relationship, inverse relationship between sleep and pain. Directly, the less sleep you get, literally, in a linear fashion, the more pain you're in. And so there is a direct relationship with that. And so you want to focus on sleep as much as you can. And I believe that dearly, and the studies back that up. And a few other things, Fred, just so you know, I don't think you were advocating going out and having a steak when you're in pain. I hope that was not there.
I mean, I always advocate steak if you like steak and want steak.
You're from Alabama.
Taking away your pain.
I would caution that a little bit on that one, but nutrition is really important. And I would say on the other side that you can absolutely get enough protein from a vegan diet, certainly, and that there's I've had a lot of patients with chronic pain or chronic conditions that have changed their diet towards a more plant-based diet, and the conditions got better or disappeared altogether, even on conditions that aren't typically considered nutrition-based, such as autoimmune diseases or chronic pain, back pain, things like that. So nutrition absolutely can play a big role. And the more you go towards a plant-based diet, it doesn't have to be vehement most of the time, but certainly you do want to get more protein as you get older. Your muscle mass goes down, and certainly you need to make sure you get that, but you can get that from a plant-based diet. And so I do believe that. And the average American certainly gets way more protein than we probably all need. So just take that with a grain of salt, but nutrition is very important. Really everything you guys said here, I agree 100%. I think it was great. It is something that's near and dear to my heart. And so as you can see, pain is something that is a holistic condition. I would say that the way to look at it is that you have pain is a way that we've survived for over millions of years. You have a level where you have tissue damage, and so we experience pain at a lower level to prevent ourselves from getting to that tissue damage. And what happens a lot of times for psychological trauma, physical trauma, emotional trauma, whatever happens, where we maybe hit that threshold in 1 or 2 or chronically over years, your body doesn't want you to get there. And so we drop our pain threshold. It's one way that I always explain to my patients to look at it, and that really your pain is real, but it also is by definition in your head. I mean, people who experience pain, they are experiencing it, and it is real, but it is also in our head by definition, because that's where we experience it. And so we can learn brain hacks and different ways of going about it to think about it differently and ease the suffering that comes along with it. And so that's the one way that I like to look at it. And I think you guys more or less alluded to that, but in a little different way. We do have a few questions. Dr. Havard asked, can you guys comment on non-orthopedic pains, such as chronic migraines, chronic abdominal pain, fibromyalgia, which we don't call that anymore, myositis, cancer pain, anything like that? Do you go about it the same way, or is there anything you do differently?
Yeah, And Dan, jump in at any point, if you disagree with anything that I say, but also jump in for sure with your perspective on these. Generally speaking, from my perspective, Dr. Havert, and what I would do clinically, the answer would be no, right? I look at, particularly with those, my important role that is coordinating with the practitioners that are more directly treating those conditions, right? There's often musculoskeletal things that we can work and improve on that can improve those types of symptoms, and particularly thinking about chronic migraines when I say that. But at the end of the day, a lot of that treatment still goes the same. How are your medications for migraines affecting your sleep, your nutrition, your activity levels, your psychological health, right? How are your cancer treatments affecting those SNAP conditions as well? So does it look different? Yes. And I'm sure that there's a layer of nuance that there's some different treatments that we could do specifically for things like cancer pain. But at the end of the day, with me, with those chronic conditions, I still go back to how does it impact that SNAP, and which of those can I directly impact, right? Most of my time I spend impacting activity, sleep, and the psychological piece. But how do we impact that? But it just looks different for those types of conditions. And Dan, I don't know what do you have to add to that?
Yeah, I agree. I think the pillars are universal. The SNAP is universal. The nuance is definitely going to change when you're talking about some of these other sources of the chronic pain, and that's definitely where making sure that we've got a team that is tackling all of this, so that the patient feels cared for, feels heard, and that they're working with professionals that identify and that are really confident in working with those different sources of pain and those different stressors that lead into pain. But I would say that the SNAP is applicable for all of these people.
And then the other question is, what are your thoughts on acupuncture to address chronic pain?
I like it quite a bit, actually, and I mean, Eastern medicine has survived as long as it has because it's got thousands of years of efficacy to it, right? And so I have had a lot of patients that have positively experienced acupuncture, and it's something that I recommend regularly. If particularly for the sleep pieces, it can be quite good for sleep. It can also be good for just taking that nervous system down, which Dan alluded to and Dr. Z alluded to, taking that alarm system and dampening it, right? I like to talk about the stovetop, which I learned that people don't call it the eye. I call them eyes, but the stovetop things, the circle where the heat goes, that's the eye of the stove. I don't know. My mom can validate. That's just what we call it in the South. But if it's on a 0, there's not a lot of heat coming from it. If it's up at a 10, it really is really hot. And so acupuncture is a great way to de-elevate that nervous system. So I actually recommend it quite often. I've got a couple good practitioners in Northern Virginia and DC that can be really, really effective for chronic pain.
And everything I've seen, we don't really have a good reason as to why it works.
Right.
And the studies may or may not always bear it out that it works. But everybody you talk to, and certainly I've had many patients who have gone and have had wonderful success from it. I've also had patients who've gone and had no success from it, but certainly worth a shot. And we always say that the placebo-nex is
very real,
1% effective. That whatever you do, you have about a 40% chance of it having some impact on pain. And so whatever that is, doesn't matter. If it works, it works. And so it's absolutely worth a shot. And there's many people who've had good success with acupuncture.
Yeah, I think about what Fred was alluding to earlier in the topic, or excuse me, earlier in the conversation about just try it. So anytime a patient is asking about something that they can try or do to positively impact their pain, try it. Absolutely, I'm all for it. The one thing that I really try to focus on and direct people towards is intervention they have ownership and control over. So things that they can do themselves so that in the moment they can positively impact their experience. And the tricky thing with acupuncture or dry needling or some of these other interventions is that you're reliant on another healthcare practitioner to provide that. But that's the only thing is I want to make sure that I'm coupling these interventions with something that they can do themselves.
Yeah, and I think this is sort of, as I said, this is a microcosm of sort of medicine in general. We see this all the time. People get chronic pain, and then they worry about the pain. As you said, you don't go fishing. or you don't go for a walk, you don't go play tennis, you don't play with your kids, and it makes you less active, which makes you have more pain, which makes you depressed because you're not actively part of society, which makes you have more pain, and it snowballs. And we see this in many, many things. You know, happens in COPD. If you have emphysema, you don't want to go for a walk because you're afraid you're going to get short of breath. And so you don't do it, which exercise is one of the best things for emphysema. Same thing with cardiac chest pain. You're worried if you had a heart attack or you get chest pain with that activity, and you're worried about going, so you don't do it. Well, obviously, one of the best things you can do for coronary disease is exercise. And so it all snowballs. And this is something we see in so many things in medicine, where fear of the thing sort of brings it on or makes it worse. You know, it becomes self-fulfilling. And so, you know, this is, you know, all the things you said, like I said, are great for chronic pain. They're great for so many things in medicine. So yeah, you guys really did a great job presenting this and giving a nice overview of medicine in general. You know, I always say it comes down to 4 things. You know, it's sleep, eat right, exercise, and you put the P in there. I say the 4th thing is don't be stupid. You know, don't drink too much, don't smoke.
I mean, I think that could work. You know? it prolongs the acronym, but that's fine. You know.
Good.
Just SPAD. Yeah, you can add that in there.
So,
yeah, that's awesome. Yeah, that's awesome. Yeah, and I mean, and I think it's the just try. You know, Dan said it a couple of times, and that's the hardest thing. And that's why I tried to set the context early of like just try is also really hard for a lot of people. And so not belittling that experience at all, but coming around to that concept of I just need to try something, because particularly with the exercise-based stuff, it can feel really intimidating. And also a little begets a little bit more, begets a little bit more, and all of a sudden you're around the neighborhood, and that's a really big thing. So yeah, I mean, it's a journey. It's absolutely a journey. The patient that I mentioned that went fishing, the end of that story is she actually rush planned her trip and went hiking with her husband for 3 months, or excuse me, for 3 weeks after 3 months of treatment. And then she was my patient for another 2 years, and it was like this. And we did our journey, and that's where we left it. So it's one little step at a time, as best as we can.
Well, that's great. I think you guys really did a great job presenting this, and I think this is, like I said, a really important topic. Obviously, we had a lot of people on, so thank you all for joining. Thank you, Dan, and thank you, Fred, for not only joining today, but for all you do for our patients. And we'll continue referring people to you guys. If you have any questions, you can feel free to email the practice, and we can send them, those over to Fred, and we'll try to put something on this on our website too. So, but I hope everyone has a great night, and hope you all sleep well and are pain-free.
Don't forget to sleep.
All back. I like it.
But just snap. That's all it is.
Yeah, that's great.
That's all you got. Awesome.
Right.
Thanks everybody.
All right. Have a great night, everybody. Take care.